I think we should start, otherwise it'll be unfair to those people who have joined. So if that's okay. So good evening, everybody. I am delighted that all of you have joined and welcome to this very important webinar to discuss about the end-of-life care and the recent Supreme Court judgment. Uh, this has been organized by Vidhi Center for Legal Policy, which is a legal think tank that has been doing enormous, awesome work helping governments to draft laws, all kinds of things. And amongst the many people who are involved in the work that we're doing, a special welcome to Dr. Dhwani Mehta, who heads uh, the health aspects of law. Uh, then we have Dr. Rajkumar Mani, who has been a doyen in this area of end-of-life care. Should have gone to jail many times if he had got frightened about, the laws, etc., right from, I think, more than 25 years. Then we have Professor Naveen Salins, who heads the Department of Palliative Medicine and Supportive Care, the Cancer Center at KMC Manipal. He also is the Associate Dean in Research and has done an enormous amount of work. They brought out a document called Blue Maple, and he has got enormous practical experience in handling end-of-life care, just like the others. Then I would like to introduce Dr. Rup Gursahani, an eminent neurologist with special interest in epilepsy, but now he is the flag bearer for palliative care in the neurology space and has been doing enormous amount of work. And finally, my very dear friend who's going to take over from me and kind of, conduct this whole discussion is Dr. Rajni Bhatt, a very eminent pulmonologist who has got enormous interest and practices palliative care in pulmonology. So I thank everybody who have joined. I thank Vidhi Center for Legal Policy, and the co-host is the End of Life Care for India Taskforce, which is an informal organization of three professional bodies: the Indian Society for Critical Care Medicine, represented by Dr. Mani. He is the chairman of ELICIT. Then we have Dr. Rup Gursani, who represents the Indian Academy of Neurology, and I am Nagesh Sharma, representing the Indian Association of Palliative Care. I happen to be the medical director of Karunasha Hospice in Bengaluru and Bhubaneswar. So over to you, Rajni.
Thank you so much, sir. And I thank everyone who's joined in this evening. It's a weekday evening, and I'm truly, glad to see so many people express an interest in this conversation. I'll just start with sharing a few slides to set the context of where our discussion is going to go. And I'm then going to invite Dhwani also to share a few of her thoughts. We've received a lot of questions after the last conversation hosted by Vidhi about navigating the challenges in end-of-life decision making, especially in light of Karnataka's historic law. So I'll start off with just a few thoughts that I thought, just a few words and thoughts that I thought would help us understand the context of decision making here. The way medical science has progressed right now, it seems like we can stretch the life as measured by a pulse, by a blood pressure, by an oxygen saturation, interminably like a rubber band with the use of many, many different interventions. But does that really help us in preserving quality of life? I think the COVID-19 pandemic did set a learning stage for all of us to recognize that there is a limit to what modern technology and interventions can do. And this historic ruling that came in, order that came in Karnataka has actually helped to bring this conversation back to the fore, a journey which had started many years ago. Through the constant efforts of many of the eminent doctors who are there today on this webinar as well, who have been opining and reading and been, their advocacy in this area has been admirable. And that's what's brought the conversation here, where we're now able to actually think of implementing things in a much simpler way on the ground. We are always guided by the principles of bioethics in all of our decision making, along with all the marvels of medical technology, we never can forget that the most important thing for us is the patient's autonomy. So autonomy is an essential component. It's the bedrock of our bioethics. But along with the patient's autonomy, I think we should also keep in mind that there is a physician's autonomy as well, of offering only those treatments which will do no harm and those treatments which are in the best interest of the patient. And that's where it really matters for us to understand and take our clinical skills beyond diagnostic to prognostication and quality of life, and also know when it is not essential to offer a treatment just because it is available. Um, there have been a lot of ground setting documents that have come out from the Indian Council of Medical Research, from the FICCI, from many other organizations, which have all been about allowing for greater acceptance and implementation. And one thing that is always challenging to me is the fact that in our clinical work, we do not use the word euthanasia or passive euthanasia. However, that is the language that comes into the legal orders that come about and very often into the press. So I think it's important that while we understand the layperson's understanding of euthanasia creates this moral, ethical conflict for us as doctors who are taking care of people with terminal illness or life-limiting conditions, that word euthanasia doesn't come in. What comes in is best interest of the patient. What comes in is ensuring that quality of life is supported and that suffering is not prolonged. So very often when we hear conversations in media, it's about, aren't you going against your Hippocratic oath, or aren't you going against the principles of the practice of medicine? Well, for one, the Hippocratic Oath is no longer the one that we go by. There are modern World Medical Association oaths, the Declaration of Geneva, which are more contemporary and accepting of the difficult challenges that we face and how to resolve those issues in an ethical manner. So I don't think there's a conflict that exists over there. We do understand that one important thing is the doctrine of double effect, which is that when I have a patient who has a lot of suffering, who does not have a good prognosis, where I cannot promise that there will be alleviation of the underlying medical condition and possibly a worsening of quality of life with a huge burden of suffering, then if I give the patient a medication or offer
चलो मैं जाऊं
a pathway, which in that situation may sometimes hasten the process of dying, that by the doctrine of double effect is still doing good for the patient. And that is actually a process which is called allowing natural death to occur. The Indian Society of Critical Care Medicine, the Indian Association of Palliative Care have come together to update the guidelines from 10 years ago, which was in 2014, along with the neurologists of the country. And now we have a very comprehensive set of clinical guidelines that can help us in our decision making. Yet we see a lot of hesitation, despite the efforts, despite the despite the amount, the body of literature that is there to support clinical decision making. So it's fabulous that the Vidhi Center for Legal Policy has also come out with some easy references for practitioners. And I would strongly urge all of you, either immediately after this discussion or at your leisure, to have a copy, download this copy of this. It's one of the simplest things that will help you for your decision making in challenging situations. And with that, I'm going to go on to asking, one of the challenges that we face is that while there are so many clinical guidelines, I think every day in our day-to-day practice, we will find a patient who does not fit a textbook case. So just like you have guidelines for the management of ARDS or guidelines for the management of acute renal insufficiency, and they don't always answer all the questions that a patient comes to you because real life is much more complex. And we learn our ways on decision making through that. I'm going to ask Dr. Dhwani Mehta to tell us a little bit about how do we now proceed with these challenges with the framework of clinical ethics, which our medical community has given us, and the legal framework that has been provided to us. How do we balance these two? How much do we rely on the law to show us the way in each and every instance?
I think that's a great starting point to the discussion for today's evening because that's really the crux of what we want to discuss with everyone here. And honestly, the key word here is discuss. This is supposed to be a forum where everyone can air their doubts, share their experiences, and we can all learn from each other. So I'm just going to give you a very broad overview, not of the legal history, not of what happened in 2018 and 2023, and what the Supreme Court judgment says, because I think everyone who is here is already very well versed with that and is here because there is an interest in continuing to practice the kind of medicine that they do while also being within the boundaries of the law. So, what I'm going to do instead is just take us back to first principles and remind everyone about what was the fundamental core of the Supreme Court's decision, because these are the norms that should guide us when there are complex cases, when there are situations that don't fit exactly within the framework of the guidelines that the court has laid down. That's when we go back to what the fundamental principles are and allow them, along with your clinical judgment, of course, and the ethical guidelines that have been laid down to guide what you do in that situation. So instead of asking for each kind of situation that comes up, whether this is legal or not, whether this is permissible or not, let's rephrase that and ask ourselves what is the right thing to do in terms of alleviating the suffering of the patient, providing the appropriate treatment, ensuring that the process of shared decision making with them and their caregivers takes place. And I think the answers to those we will find are not incompatible with the guidelines that the court has laid down. Also, we must stop looking to the guidelines to tell us what to do in every situation, because these guidelines were not intended to cover every kind of situation that does come up in practice. The court and the judges who laid them down do not have that foresight, they do not have that experience. They are not legislating, so they cannot be expected to take into account every scenario. So to use only the letter of those guidelines as the guiding spirit, as as the be all and the end all of what practice should dictate, might not lead us to the right answer. So just again to go back to fundamental principles, the things to remember are: one, there is a right to autonomy, which means when the patient has decision making capacity, always ask the patient and get that decision and get that answer from them. The second, as a doctor, you are not compelled to provide treatment to anyone when it is not in their best interests. If you don't think it is in their best interests, no one can force you to continue to provide treatment. Third, you cannot provide treatment where there is no consent for that treatment, either from the patient themselves or from their caregivers. And this we'll see through some of the case scenarios that we discuss and through some of the questions that we've already received, is one that is perhaps the most tricky to resolve. But if we go back and ask ourselves fundamentally, would you be providing treatment to this patient if they had refused it? And the answer is a resounding no. We will find the right answer to some of the more complex questions that come up as well. So these for me are the three fundamental legal principles. The rest are is then a matter of ensuring that they are that we try and implement the guidelines to the best extent possible with the resources available, with the structures that certain governments have put in place, but we also don't disrupt what practice was before the guidelines came into effect. It is not as if the guidelines have, are intended to change the way in which decisions were taken at home when people were not taken to hospital or refused to go, or when treatment was provided at home, or decisions not to continue artificial nutrition and hydration at home, or removal of a peg tube or I mean all of this was was happening in different kinds of settings. And it doesn't mean that this kind of practice is now illegal. Again, the framing of it as illegal is perhaps not the most helpful way for us to think about these questions. So we can, of course, discuss the more tricky issues. Uh, we want to in this forum solve everyone's well, not solve, but try and provide what we think is the best practice for scenarios that crop up in daily life. But yeah, my only word of caution here is to not uh, expect the guidelines themselves to cover and provide an answer to every kind of situation that comes up. And that doesn't mean then that what we do in those scenarios becomes illegal or impermissible. So I'll stop. And yeah, finally, the last thing, that yes, where there is really a, a moral dilemma, there is conflict, there are difficulties, the option to approach the court is always open to those who wish to seek it and who wish to clarify what their doubts are. So maybe the court should be used as a kind of last resort when there are particularly naughty questions to untangle. And maybe through the course of this webinar, we can discuss what those naughty questions actually are. So I'll stop there, and then maybe we can start, perhaps dive right in,
Yeah.
Rajni, and take up some of these.
Thank you so much for setting the stage with
Rajni, I'd like
wonderful.
everybody to mute, please. Huh? In between, suddenly we are getting unwanted expert opinion.
So I'm going to request all our participants to please check their settings and see if you can mute your audio. So thank you so much, Dhwani, for for clarifying that. I mean, I think it has been one of the issues, a thorny issue, which was on the minds of many people. I'm going to move now to, I'm going to be asking a few questions of our experts and then open it up because we've actually received a bunch of questions on the email. And we'll try and make sure that we can get through as many of them. I want to start with asking Professor Naveen Salins a question. There was a publication that just came out, which actually was it was really thought provoking. It was about the cognitive dissonance and the challenges that doctors in lower and middle income countries face with decisions around DNR. And I think what you spoke about is that we've all been practicing a certain way for the longest time, but there are socio-cultural challenges and there are legal blockades that we have maybe built in our mind in some ways, which prevents us from offering the compassionate, ethical end of life care. As Dr. Nagesh Simha had mentioned, Professor Naveen Salins and has been instrumental in implementing a wonderful practice guideline called the Blue Maple, which has sort of become like a prototype for every institution to try and implement ethical end of life practices. So I'm going to invite you now, Professor Naveen Salins, to just speak to that. Despite solid clinical literature supporting the best practices, how is it that we find it so challenging to this day? And how did you and your institution overcome and surmount these challenges?
Yeah. Thank you, Dr. Rajni, for this question. So when we wrote the systematic review, it was done by Dr. Mayank Gupta. It was his Cardiff MSc thesis, which finally came out as publication. And I had the privilege of mentoring him through the thesis process. So we spoke about dissonance when we brought about, because most of the findings that came out from low middle income countries are very similar to what we find in India. That means in the heart of heart, we know what is right. But the dissonance is that we know what is right, but our practices are exactly opposite. So recently, we had a patient who was the father of the professor of biochemistry. He was 85-year-old and had a chronic kidney disease. He didn't want dialysis, but somehow family convinced him to have dialysis, and has told very clearly that he does not, if things goes south, he does not want to be intubated, resuscitated, and he's 82, 83 years. And we get a call for terminal extubation in the ICU. And apparently, he came one evening with breathlessness, enthusiastic emergency medicine, intubated him, nephrologist concurred on the decision. And now he's on a ventilator, and we are speaking to the family of doctors. Clearly they said that my father didn't want this all these years, clearly expressed wishes. So when we turned around to nephrologists and asked that why this has happened, so the answer is yes, we really think that this should not have been done. But he came with a respiratory arrest. What else we would do? And we thought this is the right thing to do. So there are two things. It's like I've seen a movie where two eyes are speaking, you know and it's like this. So they know what is that right thing, but they are unable to do that. And for that you require a certain degree of courage and conviction, is to change your practice. And even when we started here, Dr. Simha, Dr. Rup Gursani, and Dr. Mani, even when we started Blue Maple, Dhwani Mehta was there. How we brought about the change? It didn't happen overnight. And there was a lot of staged workshop that we had conducted. But it's in the heart of heart, it was for all good outcomes. Is that if you strongly believe in something, and if you have that convictions are right, and you consistently demonstrate that you are doing in the best interest of the patient, over a period of time, it's that culture change that would happen. Right now, in our institute, it's autopilot mode. For most of the things, there are incidents like this that happens, but by and large, 90% of them, it's in autopilot. ICU is fully understanding, and they are very forthcoming. But for that, it's a slow process. We have to be very patient, persevere. But most important is to overcome the dissonance, is to constantly demonstrate and constantly challenge those ideas. Challenge in a good spirited way, which is very important.
Thank you so much. It's the consistency of effort and messaging and keeping best interests and best practices at the forefront, and building institutional culture, really. I think it's going to take each of us to be champions of end of life care advocacy in our own institutions to take it forward. And you brought up the issue of multiple specialties being involved. Sometimes there can be conflict and difference of opinion in family members, but sometimes it can also be in specialists. I'm going to invite Dr. Roop Gursahani now to speak to us a little bit about this. As a neurologist, very often we have situations where we call upon our neurology colleagues to prognosticate. Quite honestly, pulmonologists and nephrologists can also prognosticate to a great degree when they know a patient has had a chronic illness. But it often falls on the neurologist to speak more about what is the expected quality of life after that. And these can be challenging situations. So sometimes when we have a difference of opinion, there might be things related to time limited trials and things like that. So I would like Dr. Rupkar Sahani to just speak a little bit to those kinds of strategies for how do you build consensus when you have different opinions even amongst clinicians.
Oh, thank you. So that's actually a very wide-ranging question.
Yes.
So, right. So one of the first things
I
to
think
remember is that,
let me narrow it down a little bit, that in the process when you have a primary medical board and a secondary medical board as laid down by the directive, sometimes we may have to keep circling through that primary medical board, secondary medical process. So if you can just help us in that, and how do we go about defining those moments?
okay. So let me start off by first pointing out that when somebody is in the ICU, so this is somebody who has a GCS of 8 or less, probably sinking, either on the ventilator or just about to go on it, because at 8, you need to intubate them very often. And this is a situation that persists beyond 6 hours, right? Which means all reversible causes are gone. The first thing is that what many non-neurologists, even some neurologists, and definitely lay people don't recognize is that this is now an individual who has a less than 20% chance of returning to normalcy and to independent existence. So you already, the numbers are beginning to be stacked against you. And with that begins the prognostication of figuring out whether this is a life that is any longer worth living. So obviously in the first few days, the quickest decision is this person past the point of no return, brain dead? If that is so, that's relatively easy to answer. And I think we are now fairly clear legally on how to handle that, even if there is no organ donation involved. Incidentally, I was part of a meeting with NATO, where they're beginning to move terminology to the point of stating that family consent is, they're not saying is not, but may not be required for doing an apnea test. Because people are like, get a little worked up over that. So we probably will be on completely okay grounds to consider the apnea test a clinical test and to just do it, right? So that's brain death. Then comes the question of somebody who is likely to be incapacitated. And the problem is that these are not decisions that even we as neurologists can take overnight. Say, we can look at a scan of a patient with an infarct or a hemorrhage, because there the evidence is right up there, right? And you can make a guess about how this person's the next few years of life are going to be, even if everything is done. But hypoxic ischemic encephalopathy, traumatic brain injury, those are not, you can't figure this out for quite some time. So what we need to convince our fellow uh, physicians, our colleagues, especially neurosurgeons, intensivists, is to not jump the gun and do a tracheostomy and say, out of my ICU. You actually have to keep them with an endotracheal tube for at least 10 to 14 days, because that's when you reach a fork in the road. Either you de-escalate at that point and end up with a palliative extubation, or you start on the long, hard road of a person who's going to live in a permanently dependent state. Some people do improve over the next few months, usually traumatic brain injury, but that's a small number. So this is the road that ideally, I mean, this is the path that ideally a neurologist or anybody in even intensive care should understand. And that's when prognostication actually becomes a real exercise, and frankly, a fulfilling exercise. But there's one more challenge, and that is that people who are willing to foresee, and enough of us foresee, and people have enough experience to foresee, but not many are willing to foretell. And that's where palliative care skills are required, because foretelling needs communication skills. That then leads to shared decision making. All of that then finally comes together. So I'm presuming that in this audience, everybody would have understood the kind of the jargon that I have used, because to ask palliative care, these are fairly straightforward. But if anybody hasn't understood any of these terms, please put them up in the chat box. I'll answer them individually. Is
Thank
that
you so
enough?
much, Dr. Roop,
Thanks.
because that did help to clarify that this idea of a time-limited trial and repeated conversations with all the specialists involved, with the family members, trying to ascertain what the quality of life could be and seeing if that would be according to the patient's preferences can be a thing that goes on maybe 2-3 days in some situations and could be 10 to 14 days. I'm going to make one point over here, which is that a lot of these things that we will be discussing today will not take into account financial constraints to conditions that lead people to be on invasive organ supportive measures in an ICU. We're going to focus primarily on the clinical ethical uh, frameworks on decision making and how the laws support that. And where you do not need to worry or fear the law. Because there is plenty of clinical literature to back you up and experts' opinions to back you up, as well as precedences in the law. I'm going to ask now Dr. Mani to come in and help us with one more thing. Okay, so, we've spoken about the fact that Dr. Roop mentioned that you need the palliative care skills to really communicate and bring the consensus amongst clinicians as well as family members to understand really what the patient's preferences are and what would be the best interest decision for the patient. These questions come up quite often with the invasive organ support measures like ventilation, like hemodialysis. Two questions for you, sir. One, people find it easier to discontinue hemodialysis than to move towards taking off a mechanical ventilator. Something to address that, as in, is this the same really? Is terminal extubation or terminal weaning, as we call it, the two procedures that are done, are they equal, and how would you frame them for someone who is going to consider that? Second, who is qualified to do that procedure? And do we really always need a palliative care physician on the team, or is it more a matter of having a trained palliative care approach? Is knowing that we have a shortage of palliative care physicians across the country. So how do we scale up to the needs at this point?
I think it's a basic need now, well recognized in the critical care circles, that you have to have certain basic palliative care skills integrated into the critical care service to achieve the quality we aim for, to achieve the family satisfaction, and to achieve good decision making. Not only end of life decision making, or also any decision making outside of end of life care. That is very well settled now. Since the early 90s, there's been a process of integrating palliative care skills and outlook in critical care management, starting with Randall J. Curtis in the early 90s. So this is well settled, at least in the developed countries. And this idea is creeping up here. It is very useful to have a palliative care specialist department for advanced skills, for where you can take their help. However, what is mandatory, what is essential, is developing those skills in our own team. And that starts with not just focusing on organ support, on just rescue skills or in curative management skills, but in suffering focused, patient centric approach. And that is an essential. It is not something that is dependent on a palliative care department in the institution. This has to be understood, and this has been our campaign for the last 20 years, to integrate these skills into critical care and to emphasize that patient centricity, which includes autonomy, that is valuing and respecting the choices of the patient, or directly or represented by the family, and also whatever is involved in ensuring comfort. Okay, the freedom from physical pain, psychological pain, spiritual pain, and other sorts of discomforts. Not only with the patient, with the family also. The patient centricity extends to the family centricity. This is one thing. Now you ask me about, is it the same for terminal extubation and terminal weaning? I mean, see, the premise is the same. premise is not to impose a burden that is unnecessary. In fact, it's harmful. It is not ensuring any dignity to the patient and a comfortable end, which is the goal of every human being. The terminal extubation has the merit that there is a quick closure. This is the premise, and then there should be an immediate response to that premise. That is extubation. That's natural. What you must ensure is, of course, prior analgesia and sedation, ensuring that the end comes as peacefully as possible. Terminal weaning is a much slower process. It is not ethically that well defensible. Okay, once you know that this is not useful, this is burdensome, yet you allow a prolonged process of removal, and that doesn't sit very well. And there has been a study called AREEV study, which has examined the psychological impact of the two with the family. In fact, the psychological impact is much less with terminal extubation rather than weaning. So, in actuality, it is the opposite of what we imagine it to be. We think weaning will be easier to the family. That's not so. Now, this process of terminal extubation, whatever withdrawal there is, withdrawal of ventilation is the most dramatic. Okay, withdrawal of dialysis is in, withdrawal of vasopressors is in. Withdrawal of vasopressors, nobody knows. I mean, you just stop, and then end comes quickly. Withdrawal of the premise is the same, but the emotional impact, okay, anticipated emotional impact varies and is maximum with terminal extubation. And there, the head of the unit, the champion of end-of-life care, should be there. Maybe perform the process himself or herself and be there for the family, for queries, for apprehensions, for hand-holding, for your reassuring presence and your calming influence. This is very important. How you actually do these things. This can't be spelled out in law or in guidelines. Well, we can allude to it, what you must do, but the actual doing it, and have had the occasion doing it a number of times in the last 2 decades, and this is a skill which can be honed, can be improved upon, and here comes more easily as you do. But firstly, you have to overcome, you have to cross the Rubicon of fear. Fear of various kinds, not just fear of the law, your own psychological fear of what will happen if I extubate. It's being done all over the world. It's a common mainstream practice in most advanced countries. So why should it be such a big barrier? The dissonance that Naveen said is because you haven't done it before. The dissonance dissolves. If you make bold to do it once, there you need conviction of the correctness of what you're doing, the morality of what you're doing, the science of what you're doing. It's science also. If it is not useful, you remove. That is science. You don't bandy about. You don't hedge and haw. You go ahead and stop the debates.
Thank you so
I
much.
answered the 2 questions, or is there anything left?
No, thank you. That was fabulous. That is exactly what I was seeking from you, which is the fact that one, while we speak about the process to be followed, we must address the worries and concerns of young practitioners who are anxious, who want to do the right thing, but as you said, have not been probably, exposed to the correct technique of doing so. I know that for me, the situation was different because I came from a system of training where end-of-life care in ICUs was already systematized. And the discussion, and I was exposed to it from my early days as a medical student or as a critical care fellow, as this is the process as it is to be done. Being led by the head of the unit, as you mentioned. So I'm glad that you, described the process in a way that I think it is essential that the non-abandonment of the patient and the family at that time
Precisely.
yeah, I think that part was really important for us to note, that it's not an abandonment of care. It is just a cessation of invasive measures and continuing a palliative line of treatment at that point going forward. Um, Dr. Nagesh, I'm going to come to you as the palliative care expert over here. And some of the questions that have been on people's mind is it essential to have a palliative care physician as part of the primary medical board or the secondary medical board? What would be your thoughts on that? Because or is it because this would place a burden on hospitals which do not have it, and that would mean that you're kind of actually dealing, because some of the questions that came up from audience members who were on the last webinar was that, oh, if a patient comes to me now without an advanced medical directive, and the family is refusing intubation, am I still bound to go ahead and intubate and then set up a primary medical board, secondary medical board? We don't have a palliative medicine physician available. Could you tell me a little bit about the role of the palliative medicine physician and the expansion of that role into other specialties? How do we make sure that this directive is actually followed in this widest way possible?
Thank you, Rajni, for that question. I don't think it is at all realistic to insist officially or legally that every primary/secondary medical board must have a palliative care physician. I think that is creating trouble for all of us, including people who are in the area of palliative medicine. I think, as my friend Rajmani has already said, that the principles of palliative care have to be imbibed. Now, if you are fortunate in your institution to have a person with a palliative care background, you can involve that person officially, but equally important is that on the sidelines, this person can guide the conversation, the approach, the counseling of the family. So the palliative care team, if existing in a hospital, can do an enormous amount of work. But it would be, senseless to say that it has to be mandated by law. Then we are going to get into very bad trouble. But if you have a palliative care team, and if you feel that you can use them officially as a part of the primary or secondary medical board, and please understand that it does, when the discussion is going on, it doesn't mean that they are the only three people of the primary medical board are going to talk, right? You require that as a part of the Supreme Court directive. That's good medical practice to take opinions from people. But you can always call in others on the sidelines and try and discuss, and more importantly, to discuss with the family members. And that would help in decision making. Now, I know, for example, that you're playing a very important role where you're working. Okay. I know that Roop Gursani has got a wonderful person who's part of the palliative care services in the hospital. And that person and the other team members always come into the picture. So I think that is where, I stand, that, as Raj said, we all need to understand the principles of palliative care. And if you have somebody who's specialized in that, take the help of that person for difficult conversations and proceed forward.
Thank you so much, sir. I'm going to come back to Dr. Rupkur Sahani on a question from one of that was sent in to us. And, it was about something that you brought up about brain death, and the fact that it's a clinical determination that a patient is brain dead. Now, in the past, we've been limited because of, in terms of being able to withdraw from the ventilator based on whether this patient is a candidate for organ donation, and the family's consent for it. Can you help clarify whether this is an absolute essential part of it? And even if this patient is not going to proceed with organ donation, what would be the process that one can follow? Is there any precedent that we have for this?
So the only precedent is legal precedent is a consumer court ruling from Delhi, where a hospital that held a brain dead boy on the ventilator was fined for doing so, right? In addition to that, I think a couple of other things in the Aruna Shanbag case, it was mentioned that this was no longer illegal. So that story is over. I think there have been enough mentions in our own guidelines. I think even the MCI at some stage stated that if somebody is brain dead, story over. And then we have the Kerala government putting out an order with saying that if somebody is brain dead, then you should not. And look at it this way. It really depends on who's paying for it. If it is, if you're in a public hospital, you're a steward of scarce resources. You should not be ventilating a corpse. If you are not, if you're in a private hospital, the family is paying and the family insists that we are going to keep this patient on the ventilator forever, so be it. I mean, at some point, you can set up, say, ventilators outside at home and stuff like that. But if insurance is paying, somebody is going to get into trouble sooner or later, right? Because insurance is going to say, we are not paying for this. And then the concerned clinician is going to be in a soup. So how do we handle this? We have to handle this understanding that we are still, maybe it's still not clarified in a specific statement or law by government saying that you can take a corpse off the ventilator. But I mean, it's so obvious, and Dhani can come in on this.
Yeah.
It's so obvious that I wonder why people even get confused about this.
Absolutely. And I think there are statements from, or at least the intent from even the National Organ and Tissue Transplant Organization, NATO, is very much that brainstem death is precedent, obviously, to organ donation. So you can't, I mean, unless you have certified that, there's no question of proceeding to organ donation. And these are two separate facts. One is not contingent on the other. Brainstem death and the fact of brainstem death is not contingent on whether someone consents to organ donation or not. So I think NATO has also been trying to encourage this kind of screening of patients who are brainstem dead, and encourage reporting by hospitals on this. And yes, Dr. Mani, you wanted to come in?
Say that the recent Ministry of Health guidelines on withdrawal
That's right.
clearly states you should remove if there is no organ donation in question. The brain death is certified. So, and I mean, this was a draft bill which was put up, and this is going to be fine. I mean, in the final also, this is going to be there.
That's
okay,
right.
that you officially from the government, you have the leave to remove ventilator from brain dead persons who are not organ donors, potential organ donors.
Thank you so much. I think all three of you have made it categorically clear that it is perfectly all right, ethical, and supported by precedents in law that ventilation can be discontinued in a person who is brain dead, but whose family is not proceeding with organ donation as well. One of the questions that's come up from people is that how do we document this process of decision making? People have sent in things like, consent forms which are do not resuscitate, consent forms or refusal of consent. And this brings me to the question, which is a thorny point for all of us who have been working in this space for a while, which is when we wash our hands of the responsibility. And very often the documentation you find in files is that family has refused intubation and hemodialysis and ICU care, and they understand the risk to patient's life, and they are taking to the ward or taking home on their own responsibility and will not hold the hospital accountable. And then you take their signature. And it's such a burden to place on a family of a critically ill person who is near death to have them sign something like this. And so this question that came up about documentation is how do we document this process? So far, we just document a conversation that happened, and then they take signatures on refusal of treatment. And refusal of treatment is not quite the same as a consensus shared decision making in the best interest of the patient. So I'll just request any of you to come in with, just examples of how we would document this process. Dr. Mani, Dr. Rupo Sahani, any of Dr. Naveen Salins.
See, what we have been doing, is, of course, documenting the conversations. And in the conversations, when the prognosis is discussed, the prognosis and what was discussed and what was understood is there. This can be in the case file itself, in the running case notes. It doesn't have to be a form. Although in one of the places where I work, there was a form for family conference. Now, what we do now in the existing hospital, we have one form, final form, where you have the the consensus decision and what is being withdrawn or withheld, then the primary board signatures, the family member signatures, the primary board signatures, and the secondary board signatures. Secondary board consists of other three physicians. We are not worked out a CMO appointee because the system is not in place. So we go as far as possible to meet with the Supreme Court requirements. So we have two boards. This is all we have. We have one single form at the end of it. Rest of it is properly documented in the case notes. So this will keep it simple. The ISCCM IAPC guideline says you have documentation at every step of the way. It doesn't mean that we have a number of forms. It means you must document whatever you're doing. And that's what a case sheet is for. It is to document what you're doing. Don't you document without a form in the case notes if you put a central line or you do any procedure? It's there. Or you may have a form. I don't mind. But then it is an additional paperwork. The ISSM IPC guideline in its annexure has a number of sample forms also. The Blue Maple has a number of forms, as a template. So you can design a form yourself, as we have done in our hospital, or you may take the templates from any of these resources.
Thank you so much, sir. Dr. Naveen Salins, can I request you to come in as well because this is also a forum for us to share best practices from people who've been doing it for a long time the right way.
Right. So we follow a simple 4-page document.
Okay.
So the first page, we call it as nothing, which is now called as a primary board, is where we endorse the medical fertility. So the page number 1 is signed by the group of treating specialists, which does not include palliative care physician, where we clearly mention the current clinical status and the reasons underpinning the decision to withhold or withdraw in detail, as what is the logical processes involved in why we are making this decision, and the names and the designations of the person signing. The page 2 of the document is the family meeting. So where we clearly mention who participated in the family meeting, where it was conducted, what is the mode of family meeting, because we had to bring the mode of family meeting during COVID because a lot of those family meeting happened on a video conferencing. And what was the key outcomes of the family meeting. The page 3 is a consent document, consent to withhold or withdraw. The consent document is written as a form of communication where family is it's because it's both in the regional language and in the English, where family clearly understands what it is and they're in agreement and what does the doctors have communicated and why what are the basically again reasons underpinning those decisions coming from the family's perspective. And the fourth page is a more of a ratification document, which is a second report where 3 independent people will ratify the first 3 pages and say that all checks and balances are in place and all the due diligence has been followed. And now actually we are auditing our practices and we have almost close to 2000 of these documents that has been gone through. So we are doing a 5-year audit to see that how these processes have been in place.
Thank you so much. That's I hope that provides an example of different methods in which each place can look at what would be feasible, but incorporating all of these principles into your documentation process, and do it in a way which really reflects that this is shared decision making. It's a clinically valid decision, and it's a procedure that's being followed in accordance with clinical guidelines, in full, with the proper legal support as well. I would say that, there is, with all of these advices that we have received, I think a lot of us will feel a lot more confident about going ahead with this procedure. I'm going to move now to a different topic, which is, where we've spoken a little bit about withdrawing from mechanical ventilation, withdrawing from hemodialysis. Artificial nutrition and hydration becomes one of those difficult topics for many people when it comes to medical interventions in someone who does not have a good prognosis, a good quality of life, or who is not expected to live long. Nutrition somehow seems difficult for people to withdraw. Some people might have feeding tubes. Some people may have IV lines in place. Withdrawal of artificial nutrition and hydration is really withdrawal of an invasive medical intervention. Questions that have come up in certain cases recently in the news as well. I would like our experts to share their thoughts about, one, the equivalence of stopping cessation of artificial nutrition and hydration to the organ supportive measures like ventilation and hemodialysis, and two, what might be the best practices to create the least difficulty for patients or families in this situation. Dr. Mani, I'll ask you to begin.
You see, this topic came up with the Harish Rana case, where for 13 years there was a boy in a permanent vegetative state, and the elderly parents, they couldn't cope at a certain point, and so they approached the court to have a medical opinion whether passive euthanasia could be employed. So, which was not correctly interpreted by the High Court firstly, and then by the Supreme Court. This was dismissed because they said active euthanasia is not allowed. But then active euthanasia was not asked for. And they said there was no life support being employed, which is again being ill-informed. The one life support in vegetative state is the artificial nutrition and hydration, and which was being medically instituted, not provided by the natural route. So on both these, wrong premises, they didn't allow a medical panel to be set up to look at this case, in the light of best interest of the patient. The whole focus shifted on the economic burden to the family, and so the Supreme Court provided for it by asking the state government to provide help, and the Ministry of Health also looked at it. And I was also one of the panel to advise them. I advised them saying that we don't want to create another Aruna Schonbaum. We only provide these logistic helps, okay, and not look at the dignity of dying, which is a right with the patient, which should be in the central issue. You sidestep that and you're just looking only at the logistics of care. That is only creating another Aruna Schonbaum. In spite of pointing this out and advising positively that a medical panel should be set up and communicate with the family about removal of artificial feeding and what to expect and how to support the patient from the point of view of any onset of suffering. Okay, so what we are not able to grasp, okay, here is that artificial nutrition, when it is the only lifeline for a vegetative patient, is much like the endotracheal tube and ventilation for a person who can't breathe. They are technically the same. In principle, they are the same, but emotionally they are different. We understand. The vegetative patient is usually not in the ICU, usually at home and being cared for years and years. And to not institute a medically invasive, nutrition process is a big decision which so far our medical fraternity is not able to cope with or tackle. Leave alone counsel the family. Okay, they are not able to come to terms with it themselves. This question has been asked many times around the world. There are so many cases in the public domain where the US courts and European courts have allowed removal of the feeding tube. So this precedence is very much there in a number of cases. What we shouldn't do is to encourage. You see, you can advise them not to introduce a tube or a peg feed. Okay? But by all medico-legal possession in the country and around the world, we can't advise an informal removal of this. Okay? Without explaining and without going through whatever procedure that has been laid out, whether they are in the hospital or in the home. Okay? In the home, you can go through the process laid down in Aruna Schonbach case, because in vegetative state you have time. It is not time sensitive as in the ICU. You have time. You can appeal. Of course, this family did that and failed, but then next time it can be more helpful if we represent properly. Or you have the option of transferring the patient to the ICU, to the hospital, for the purpose of deciding on removal of an artificial process through the route advised by this Jan 23 judge. Okay.
I'm just going to, ask a question here. There's many palliative medicine practitioners in our group of participants here. This is a condition that we face often in our home care situations, that a patient is deteriorating. They may have a progressive neurological or an oncological condition. And in that situation, when it becomes evident that the patient is active phase of dying or in the terminal phase of life, we explain it to them in terms of, at this point, the patient is not really feeling hungry. Hunger is not a need. We know that this is a process that's going on. And we just stop using the tube. We don't speak of removing the tube, but we're not introducing any nutrition through it. We may stop using the IV line. We may stop using the Riles tube or the gastrostomy tube. Does that decision still lie as a shared decision making with the patient surrogate, and the doctor? Is there really a need to make it part of the legal framework? I'm just asking you this question so we can clarify it for all our practitioners that these options exist, and how would we go about doing that? May I request Dr. Naveen, Dr. Nagesh?
Yeah, Naveen, but I would like to invite Stan McCadden, who has been involved in a lot of home care stuff. Stan, would you like to?
Professor Stanley McCadden, yes. In the home care setting, I think, Dr. Nagesh started off by saying that Dr. R.K. Mani has risked going to jail many times. I think that would also apply to many of us, and definitely to you who have been offering palliative care in the home care settings for so many people, and will find a lot of these discussions bemusing as to why is it that we are discussing so much about what is in the best interest of patients.
Thank you. It's really wonderful to learn so much from all the experts on the panel. And yes, I think everyone, if you ask, where would you like to die? We would all say, we want to die at home. But the reality is that there is not enough good palliative home care available. And to answer this question of hydration and nutrition, it is the time that you spend with the family to explain all this. The difference between a dry mouth and thirst. The family needs to understand that these people have, over a period of time, their body is withdrawing from all these things. So they do not have that hunger. They are not distressed by hunger. What they are, excuse me, what they are distressed is the dry mouth. And all they need is you teach the family, you sit next to the person, take a small vessel of water and a cotton swab and, moisten the mouth. Don't put too much, otherwise they may aspirate. Just and keep them in a position that, even if there is some secretion, it will come out. But keeping the mouth moist is enough. And that is what is comforting. So once they understand that, and IV fluids, if you continue IV fluids, their body is not going to handle those fluids. They get all bloated up. I remember in the US, this was almost nearly 20 years ago, when we visited an aunt of ours. She was one of the leading gynecologists in Tirupati. She must have delivered, obstetrician and gynecologist in Tirupati. She must have delivered half of Tirupati there. She was so popular. And she was in this university hospital. And when one of the young doctors came to take a specimen of blood, because, that was going on for quite some days, she said, if you come with that needle one more time, I will kill myself. So, we do not understand the distress. Putting a nasogastric tube is very discomforting. People are busy pulling it out and we are busy putting it back. And it can cause aspiration, it can cause so many difficulties. So my point is that it is time well spent. And it is time for, I'm so happy that so much of legal support is now available. And we should, go all out to provide home care. That is one aspect. And also the second aspect, which, came up earlier, why shouldn't a palliative care physician be part of the primary medical board? We are all talking of quality, isn't it? Quality of life. And that's what palliative care input is all about. You have others to prognosticate and give us all their inputs, but quality of life is what palliative care brings in, and all the communication skills, all that. And you wait for all these skills to develop. Okay, when I started 30 years ago in palliative care, the coverage in India was less than 3%. What is it today? It's about less than 5%. I may be wrong. But, so there is need for us, there's an urgency. There's an urgency, and I think this is the right time when we have legal support to make it possible, that when a person says he wants to die at home, our legal system must make it possible and avoid delays. Now if you have a good primary medical board with all these experts and a palliative care expert, there is probably no need for a secondary medical board in that kind of situation. I don't know. I mean, I may be wrong, the need for that, because it is just delaying the whole process. Even whether you have an advanced medical directive or you don't have, it still has to go to the secondary medical board. And from what I understand, the process of it, that the members of the secondary medical board must visit and agree. It's not just ratifying a decision. They have to come and visit.
No.
Mani
Stan,
can
if I might interject, okay, let's not get confused. Primary and secondary medical board is essential, and I'd like Dhoni to come in over here. It is essential when a person is admitted in a hospital.
Yes.
You cannot, please hear me, you cannot mandate that a palliative care person has to be part of the team. Okay, it is nice to be part of the team, but till such time that we are having so many palliative care physicians all over the country, number one, whether you or I like it, the current Supreme Court guidelines, which is the law till the Parliament passes a separate legislation, is that there is an animal called the Secondary Medical Board that has to be involved. We cannot talk about unnecessary delay because we are contravening the Supreme Court judgment. How do we do that as quickly as possible? And what you rightly said, the importance of communicating and explaining to the family. But you just cannot avoid, and say that, oh, there is no need for a secondary medical board. We cannot say that now by law.
No, I understand that. No, you have explained that, Nagesh. I have no problem with that. I'm just expressing what, based on the 30 years of experience, I'm just expressing,
Agreed,
and
agreed.
I'm saying that this is the time where the law can take it up further. And, I'm sure it will happen, because we have made some good progress, wonderful progress.
Yeah.
But
The law cannot insist on palliative care or palliative medicine being part of any board. Okay, Supreme Court or for that matter, no
May I
government will do
just
that.
may I interrupt to bring in Dhwani Mehta here? I
Yes,
have a
yes, yes.
question based on this. I have a story and a question. So I'm just going to tell you about my grand aunt who had a chronic type 2 respiratory failure for over 8 years, used to be on BiPAP at home, had a hypertensive bleed, fell down, was taken to one hospital where she was intubated because of this intracranial bleed. She was brought to our hospital, and that's where she underwent a CT. And then, it was quite evident that this would be something that would leave her in a situation with not the kind of quality of life she wanted. The family was very clear that this is not what she would have wanted. The neurosurgeon, the neurologist, the intensivist are in the emergency room. They agree with the family's decision. There are 3 other doctors in the room over here. We have more than enough opinions all saying that this is not the right way forward for this patient with their stated preferences. It isn't that the primary and secondary medical board must take 48 hours. These decisions can be in less than 48 hours. They can all happen simultaneously. It's about how we build the communication networks and SOPs and processes in our hospitals. So I think, everyone's point is very well taken, that the role of the law here is to support the process and not hinder the process. So I'd like Dhwani to speak a little bit to that, about following the spirit of the law and not the letter of the law, especially when there is consensus amongst everyone.
Yeah, absolutely. And I think this is the point where, as you said, Rajni, we can use the law to our advantage to make things less complicated if we go back to the first principle. So instead of saying now in an emergency situation, you will first intubate and then you withdraw, if at the very first instance there is refusal, I mean, there is an understanding amongst the treating team as well as the family members that this is not necessary, all of this can be obviated, and you don't have to go through this kind of convoluted process which will take so much time. So I just, if I may, I just want to clarify something that's popped up in the chat, because there is a little confusion about it as far as the applicability of the primary and secondary medical boards go, which was related to the DNAR. So just to clarify again, that what I have said is that where where the patient themselves requests the DNAR, then there is no need for you to go through the primary and secondary medical board process. So what Dr. Nagesh was talking about and was insisting on is that when, yes, there is a patient who doesn't have decision-making capacity, and this kind of decision to withhold CPR has to be made, then you can then this process of both the boards will follow.
Thank you. May I request you to please mute your audio, Dr. Yes, thank you. Yes, Dhwani, please.
No, so that was the one thing that I wanted to clarify. And just in terms of yeah, as I said, the one thing that we can keep continuing to rely on is the fact that where the family doesn't wish treatment to be provided, then, then at the very first instance, then that should be, we don't need to go that extra step and reach a point where you need to have a withdrawal decision. You can document the fact that there is an understanding that this treatment is no longer beneficial, and leave it at that without having to navigate this complicated process. Because the fundamental legal principle here is that you can't be providing treatment if there is no consent. You can't be forcibly intubating someone against their will or their family members' will.
Thank you so much for clarifying that, Dhwani. The right to refusal of any kind of intervention remains So the patient's autonomy and the surrogate decision maker's autonomy remains. I'm going to just put this question for all our experts here, and then leave it open for any other questions that people might want to come up with. I know that we've not been able to address all the questions that have come to us, but I'll just bring these 2 points out that have come. One is, a lot of questions that we received were about liability, as in who is allowed to withdraw. Is it going to be the doctor's liability in case anyone comes to us with a complaint or decides to litigate? Is it going to be the primary doctor? Is it going to be the primary medical board? Is it going to be the secondary medical board? Or is it going to be the institution? And that clearly tells me that there is worry and anxiety amongst practitioners about this. And I think one of the doubts that many people have is about consensus. And some of the questions that came up were, what if one child agrees and one does not agree? So if you could speak to that, I'm going to request our experts to just chime in with just your one-line worry relieving advice for people who are concerned about that.
Drive a consensus. If you can't drive a consensus, don't take this decision. Simple.
Right.
It's possible in majority of the cases. If you get more skilled at driving a consensus as we do it sincerely, and majority of the time you get your objective. If you can't, in spite of trying, then leave it.
If you're worried about the family, I think just make sure that you have got the family hierarchy right. And for that, I suggest follow the AIMS end-of-life care guidelines. That's the only surrogate hierarchy that is up there. And ideally, if there is time, if the patient has time, then please ask them to appoint their healthcare power of attorney and cut short all the confusion.
Thank you so much for that. One question that had come up from multiple people in different states, West Bengal, Delhi, Chennai, people from armed forces hospitals, about where do we stand in the rest of the country, and how can we work towards bringing about how Karnataka has worked at making a number of experts available to be part of the secondary medical board. So I'll request all our end-of-life advocacy experts here, Dr. Nagesh, Dr. R.K. Mani, Dr. Roop, the three of you have been at the forefront of all the measures along with Mani and her team. So what is so special about Karnataka's law? How can Delhi, West Bengal, any other state work on this?
The special ingredient is Nagesh Sima.
No. Okay.
Yeah, he made sure he railroaded the health minister
no.
and the health secretary
No,
into doing it.
I would
So,
say that thanks, Roop, for that. So I have been engaging with the Principal Secretary Health, and he has understood very well. So in the Secondary Medical Board, what is required is that there has to be one nominee by the District Health Officer or the Chief Medical Officer. So in fact, Dhwani and her team have prepared a huge document for the Odisha government. And in fact, Dhwani came to Bhubaneswar because we have a Karunasha in Bhubaneswar also. And nothing happened after that. And I was with the Principal Secretary Health of Odisha. And I have again reminded her, and things are there. But what was suggested in the Supreme Court, if you remember, Raj, okay, I was watching that live, that you were trying to convince the government guy that there is a panel that is already appointed in the case of withdrawal of life support treatment, particularly in the case of patients.
Brain death. In the case of there's a brain death committee already.
No. Wait. It was only for organ transplant. If a person was an organ donor, yes. If the person was not an organ donor, you could not use that panel. Okay. Now, what Karnataka did at my suggestion is, I said, there is already a panel. Please pass an order that as far as the DHO is concerned, anybody who is in the panel for the organ donation under TOTA is deemed to have been approved by the district health officer.
Yes.
So now we have a group, we have a list of people already available.
Yes.
Now, what is my guess is that with TOTA, there weren't that many demands on this panel. If we are going to keep using this, there will be certain amount of rumbling. And then I will go back again and talk to the Principal Secretary Health and say either you expand this panel or create another panel for the sake of using it for withholding and withdrawal. So interimly, it is sorted out.
See, the Karnataka government order states very clearly that this is while the process is pending
Yes,
Correct.
for expanding this group.
Correct.
Now we mentioned this, Dhwani and myself in court, that we have a government appointed panel already who can be utilized. It wasn't given its due regard. It wasn't discussed. That's the problem. We did throw it into the ring.
So if I can come in with one more comment, and that is that the primary and secondary medical board have only one function, and that function is to make sure that these decisions are not unilateral. It can't be done by one person alone. So primary medical board has to consist of three, and typically in any large hospital, any patient in the ICU is looked after by 2, 3, 4 people. And that's standard. So 3 people is straightforward. The secondary medical board is a separate group of 3 consultants who have not been part of the primary team. It's like just an audit process. And that 48-hour is the maximum limit. You can do it 1 hour after the primary medical board has signed off on it. And an individual hospital can have an SOP which puts together this secondary medical board as and when required, without waiting for the state government to, do its business. I've been trying to convince, and I think it is working, our hospital to just, in our SOP, just have a secondary medical board. Then we are, even if the government empaneled person is not there, it doesn't make a difference. We are following the spirit of the law, which means 3 plus 3. That's it. What is so difficult about it? The thing is that those of us in large hospitals, we also have a responsibility to convince our administrations that this is doable, it's legal, and if they require, I'm sure Vidhi will be able to back this up also.
Thank you so much, each of you, for stating how other places can go about. I think, Dr. Roop, what you brought out, that in the absence of government directives, institutions themselves now need to start taking the lead about having institutional SOPs. There was a question which came about, which is like, how do we know that a request for withdrawal of care is not about financial gain? And I think we started out by saying that we will keep finances out of it. These are medical decisions. We as doctors will opine on whether withdrawal or withholding of an invasive organ supportive measure is medically indicated or is not likely to be beneficial. And therefore, this discussion opens up about whether withdrawal of invasive organ support is a valid decision or not. And here, I think what the primary medical board and the secondary medical board achieves is 6 doctors with some level of experience who are not swayed by the financial motivations of family or others. If the family comes to us with a consensus decision, our decision has to be purely based on the clinical aspects and the possible prognostication quality of life. So I think that's the way we need to approach it as doctors. Any thoughts from my experts?
You see, the checks and balances are this only, that there's a shared decision. So from the physician side, you got to have beneficence and non-maleficence. There's no financial consideration there. It is balancing beneficence and non-maleficence. So that balances out any other motivation by the family.
Can everybody mute, please? Can everybody mute? We're hearing unnecessary side comments, please.
Thank you.
Not you, Raj, for heaven's sake. Please go on.
I thought it included me. So, what I wanted to say was just this. What Rajini was saying, I just wanted to add this bit, that this is why the checks and balances. This is why you're going to follow the algorithm for end-of-life decision making as defined by the guidelines, ISCCM, IAPC guidelines, and what we are discussing. The shared decision making is this very thing that will stop the unwarranted decision making or premature jumping to conclusions,
Thank you so
or
much, Dr. Mani. And I just
or
I
you
just
know
want to
the
bring this slide up
the-
over here to say that I don't see financial anything to guide our clinical decision-making matrix when we're looking at decisions about withholding or withdrawal of life-sustaining treatment, or some nowadays I've started using the word invasive organ supportive measures, because withdrawal of life-sustaining treatment again is a word that is loaded with emotion for family. And as long as they realize that while we may be withdrawing invasive measures, we continue with all the supportive measures. So I'm going to hand it back to Dr. Nagesh. We've had a 90-minute discussion. We've done our best to address most of the questions that have been sent in to us. And I'm going to hand it back to Dr. Nagesh and the Vidhi team for closing remarks.
Thank you, Rajni, for conducting this webinar extremely well. I will now ask Dhwani, uh, would you like to kind of have closing thoughts, clarify a few things, or inform people about things that they have not asked because they probably don't know and they may suddenly wake up? Okay. And if among the participants, if there's anything that is bothering them, if they can put it on the chat, then I think we'll try and answer if that's okay. So Dhwani, please.
Sure, maybe I'll just end with a few key takeaways, which should help guide practice in your in your day-to-day lives. One of them, of course, is that where the patient has decision-making capacity, no need for the primary and secondary medical boards. Two, DNAR is absolutely legally valid, recording it is valid, performing it is, and respecting it is valid. No difficulties on that ground whatsoever. Three, where there is conflict, don't take a difficult decision to withhold or withdraw. And four, the family or the caregivers always have the right to refuse treatment, and that treatment cannot be forced down their maybe it's wrong to say forced down their throats here when we're talking about intubating, etc. So, but yes, the fundamental principle here is that no treatment can be provided without consent. I think these should be, three or four guiding bedrock principles, and then the rest is a matter of following the, ISCCM, IAPC joint consensus position statement to understand how exactly to approach this in clinical practice. So the law will provide the broad contours, and the actual practice of this can be filled in by what other doctors and professionals and experts have developed on the basis of knowledge and other best practices. So I'm just going to end. I mean, I don't want to have the last word here, but I just want to say here that for those whose questions haven't been answered, or there is a need for further clarification, please feel free to write to us at the email address that we had mentioned when this was advertised, and we'll post it again in the chat box over here. Two, please also I mean, we had prepared a list of a set of FAQs on this issue. We are very happy to revise that on the basis of the questions that we've received and the discussion that we've had, so that it can be more up to date and can actually reflect the practical problems that people face. And three, all of this really is a work in progress. So, I don't want to give, it's not always possible to give a definitive answer to ensure everyone against legal liability through a statement or pronouncement that I or any other lawyer can make. But the crux to keep in mind is that the right, I mean, the following and adherence of clinical guidelines, best practices, the responsible practice of medicine is unlikely to get anyone into legal trouble. And I think everyone here on this webinar and the people who have spoken are living proof of that. So this was very much again, this is a work in progress. We want to have more discussions like this. We want to be able to respond to what people's felt needs are and to be able to provide you with the tools and the guidance that you think is necessary with whatever degree of specificity and detail that will allow you to practice palliative care, critical care with a a conscience that is not overburdened or not, and a mind that is not worried about the law. So I'll end on that note. And yeah, Rajni, if you would like to say anything else to conclude.
Thanks so much, Dhwani. There was a word that was used by Dr. Bhavna Seth, who's attending, who said that she likes the word liberation from a ventilator rather than withdrawal. And I think we can all agree that the more we start thinking with the principles of bioethics guiding us in the best interest of patients, we will start recognizing that stopping invasive organ supportive treatments is truly liberation in that way. And I thank all our experts and Vidhi and ELICIT for bringing this conversation together to help all of us feel lighter and liberating us from our worries about difficult decision making at the end of life. Thank you so much.
So before I, guillotine this meeting, okay, as all of us, as Dhwani, you very rightly said, that you can't solve everything according to the law. The principle is good, compassionate communication, and to make the family feel that we are with them. If when in doubt, as you said, don't do anything, and I'm sure over a period of time things will improve. For those states that have not yet mandated how the secondary medical board representative from the CMO has to be there, you can write to the concerned authority. But in the meanwhile, go ahead with the secondary medical board, have proper people onto that, and then just go ahead and do that. And I'm sure that, if people like Rajkumar Mani are still out and not in jail for more than 25 years of working in this field, withholding and withdrawing life support, and particularly, withdrawing life support, I'm sure that is there. And finally, I would like to thank Vidhi Center for Legal Policy and Dhwani Mehta in particular for the many, many years of very, very hard pro bono work that you people have been doing, going to the court. And I can never forget Senior Advocate Arvind Datar from Chennai. The poor guy had to sit and listen to a lot of stuff from the government representative, and poor Rajmani had to stand behind and keep on bowing, yes, Your Honor, and no, Your Honor, and listening to nonsense. It's a collective effort, and we are delighted to have brought this to you. So thank you, everybody, for joining, and good night. And any questions, email it to Dhwani, and we'll get back to you as quickly as we can. God bless and good night.
Thank you so much, Dr. Nagesh. Thanks. Thanks, everybody. Have a good evening.
Good night.
See you all.
One doubt, sir. Sorry, before closing, I'm in military hospital Chennai. So if they do sign do not resuscitate, is not need the secondary primary board no role, no. Just if the relative signs, that is enough.
So the first principle, the patient or their surrogate decision maker has autonomy. So if they're refusing treatment, you respect it right then and there. There's no need of a primary.
Commandant was worried if they need not write, is it legal? Are we not is it we need not write, do not then we need not. Otherwise, what happens in a hospital is they do like do not resuscitate. otherwise they're scared and they fill up that, okay, CPR done, everything.
This has been a practice in many hospitals where and I understand where you're coming from, Dr. Divya, where people will actually follow the DNR and not perform CPR but document that CPR was done. I have never been in favor of this. We just document that this patient is not likely to benefit from this, is already having a progressive illness, and you are doing the best medical care for the patient. CPR will no longer be beneficial, right? So you just say that the patient has received the best medical care, and any further intervention would place an additional burden on the patient. And this is shared decision making. The reason why I don't like saying patient's family refused something is it burdens them with guilt. This is a clinical decision. If you can back it up based on the fact that the prognostication indicates that this patient will not have a good quality of life and it would not be acceptable to them, you just document it as shared decision making and say that the patient got the best supportive care and was declared dead at this time. Do not write CPR was done when it was not done.
And who need to sign in do not resuscitate form, ma'am? Only the patient and relatives, or how many doctors also? How many have to sign in that?
Technically, you don't need anyone to sign it if you documented this in your clinical notes. Okay. So people do it. If it was a wrong decision, consent forms are not something that will hold you up in a court if the clinical decision-making process was wrong. If the clinical decision-making process is correct, you don't need forms signed. You just need to document it as a family meeting of shared decision-making. So yes, maybe you want the signatures of those present and the treating doctor. If you are in any doubt, if the patient has multiple doctors involved, then please get all the specialists involved. But it's a shared decision-making.
Primary, secondary is only when they're on ventilator and other things.
Primary medical board and secondary medical board comes in case of no advanced medical directives. If a patient has an advanced medical directive and the patient themselves has said it, I would really refer you to that with the end of life care policy toolkit. Anytime you have a doubt, just go back to it. Most of the answers lie there. Just have a look at it. There are FAQs for doctors and nurses. There are FAQs for patients and caregivers as well. So, and then just do reach out directly to any of us. Thank you.